So I'll keep the lecture very short and precise and to the point, because this patient ventilator asynchrony, actually, as I said, it's considered a kind of complication after mechanical ventilation has been instituted. But it is something which is very difficult to tackle. It should be easily identified. And if you're timely intervening, it can be very well handled as well. Now let's understand what is it. It is again a very simple thing. And as you have been learning throughout the day today, that patient, once is put on the ventilator, there are certain settings are set on the ventilator, either in the control mode. Most commonly control mode is started when the patient is initially put on ventilation, and later on towards the process of weaning, we change to spontaneous modes depending on the patient's capacity and the stage of the disease process or the etiology for which the patient was put on ventilator. Now, what is this asynchrony? It is a mismatch. So it's an incoordination, or you call it a mismatch between two parties, that is, one is the patient and one is the ventilator. So, and this affects the various aspects of the mechanical ventilation, which is the time, flow of gas which is set on the ventilator, or flow of air which is being generated by the patient during the process of inspiration or expiration. The volume, again the volume of gas which is either delivered by the ventilator, or the volume of gas which the patient is trying to take on his own. And again the pressure demands of the patient's respiratory system. So all these factors are existing on both the sides. The time, flow, volume of gas, or pressure demands also exist with the patient and also exist with the ventilator. But when there is a mismatch, we find asynchrony. Now, ventilator during a process of invasive or positive pressure ventilation supplies the demand during the process. And it's a very common phenomenon. If you have cared for these invasive ventilated patients, it's a very common phenomenon. And literature tells that incidence is up to 14 to 85%. So it is very high. So let's see the common factors either on the patient side or on the ventilator side. So this is most commonly due to ineffective effort by the patient. We'll come to the details of that. And other one is next is the auto triggering, double triggering. The other term is the premature or delayed cycling. You know, all of us, I think most of you would have learned this by now, that when a mechanical ventilator is set, during the process, there is a cycle of inspiration, pause, expiration, and in the process, gas flow is also set. Now, various modes of ventilation have their either initiation or limiting factors. This cycling is also set by the ventilator, and especially during, suppose, for example, in the pressure support ventilation, PSV mode, it is flow cycled. So when the flow comes down to a certain level from the set value, say 25%, then the breath is terminated. So this is the process of cycling. So when there is either premature cycling happens compared to the set time, or there is a delayed cycling, then there is mismatch again, and it gives rise to asynchrony. Again, if there is insufficient or excessive flow of gas in the system compared to what it is set, then again, obviously there is a mismatch. So diagnosis can be made by inspection of flow, volume, or time curves. So most of the ventilators have, when there is a screen, you see minimum 3 basic curves are there: flow, volume, and time curves. And gradually, when you start learning this process and start caring for these patients by the bedside, if you minutely look at all 3 curves, you get acquainted with the actually one of the ideal curves. And when there is discrepancy or mismatch, you will be easily able to identify it. So how do we manage it basically? First and foremost, remember that whatever is happening to the patient at the interface between the patient and the ventilator, there is also a primary etiology which is existing inside the patient. Remember, this primary illness or the disease process is the root cause for which the patient has been intubated. So organ dysfunction in the form of respiratory failure has set in, and that because of that only the patient is on the ventilator. So if the primary etiology is persisting or worsening, or it is changing, or other complications are setting in, then obviously this mismatch also can happen. So this is a patient factor. Also, you need to control pain, because Patient who may not have any bodily injury, obvious bodily injury, but when they're lying on bed for a long period of time, and when there are so many pipes and catheters are hooked onto the body, they are in tremendous pain. And these patients, poor patients, they cannot